That'll be terrific. Okay, so I'm just really pleased that everybody's been able to join us today. And before we actually begin, and before I give an outline to our webinar series, first of our webinar series today, I'd like to hand over to Kathy Liane, who will be able to conduct our acknowledgement of country. Kathy Liane, join us.
Thank you, Leslie. I'm going to try something a little bit different today, so please bear with me. But before we begin, I would like to invite you to take a moment to reflect on where you are and your connections to others. I think we'll just take the next couple of minutes to shed any thoughts that are racing around in your mind, any worries and tensions you may have brought with you this afternoon. Put them aside with the full knowledge that you can pick them up again in 2 minutes if you choose. So I'd like you to sit and get comfortable with your feet touching the floor. Feel the connection of your feet to the floor. Rest your hands in your lap. If you feel comfortable, you might like to close your eyes or lower your gaze. Now just take a moment to notice your breathing. Focus on the feeling of breath entering and leaving your body. You may notice the breath in your nostrils or mouth. You may notice it in your chest, your shoulders, or your tummy. Just notice the feeling of breathing. Now take your focus to your feet and feel that connection to the floor. This floor connects you to a building. It might be your home, it might be your workplace. It's a building where people come and meet, love and laugh. Imagine that the building and the floor beneath your feet dissolves. Your shoes dissolve, and your feet are now connected to the dirt underneath this building. Imagine the feeling of your feet on the ground. For millennia, Aboriginal and Torres Strait Islander people have walked on this ground. They met here on this land, living and learning, connecting and valuing this place. We take this moment to acknowledge that this land where we are meeting today is the traditional lands of Aboriginal or Torres Strait Islander people. We respect their spiritual relationship with their country. We also acknowledge Aboriginal or Torres Strait Islander people as the custodians of this land, and that their cultural and heritage beliefs are still as important to people living today. I invite you to reflect deeply on this acknowledgement and pay attention to what it means to notice the footsteps of the people who have walked here before. Notice where in your body you feel the connection. Notice any emotions that arise for you when you connect deeply and respectfully with the custodians of this land. And notice any thoughts that you currently have. Now bring your attention back to your feet, back into the room in which you're sitting. Notice the feeling of your breath entering and leaving your body. And now, with one deep, mindful breath, return to the room, open your eyes, and let us begin. Thank you. So I would like to acknowledge that the land I'm on today is the land of the Kaurna people. Always was, always will be. And I'd like for you to acknowledge the land and traditional owners where you are sitting. Thank you.
Thank you, Kathy. That was such a beautiful, apt way of opening up this webinar today. Thank you so much. I'd like to introduce everybody today who's going to be speaking with you. You've just heard from Kathy Liane, who's the Manager of Strategic Partners in South Australia for the Women's and Children's Health Network, specifically with Indigenous families. Kathy, would you like to provide some additional information about yourself?
Thank you. I feel like I've done a lot of talking. Yes, I sit as a consumer representative on a number of research projects, either in my role at Women's and Children's or in my role in community. I also, in my work at Women's and Children's Health Network, support the engagement of consumers in our work, and another part of my role is to work with our partners, and key to our partnerships are our research partnerships. So that's the space that I sit in, working between consumers and research, but all in the Aboriginal health space for women and children.
That's great. And you also sit on the Women's Health Research Translation Network committees. That's good. On our steering committee as one of our consumer advisor advocates, and also Kathy chairs our CCI subcommittee.
Sorry, I forgot the most important part.
No, that's all right. That's absolutely fine. And my name is Leslie Arnott. I am the Consumer Partnerships. I don't know why my slide keeps doing this, but anyway, I'll bring it back to our beautiful pictures. I'm the Consumer Partnerships lead in WHRTN. I've got about 21 years experience as a consumer advocate advisor as well. I'm the co-founder of Lamaze Australia, which is a birth education and consumer advocacy organization around maternity, birth, and early parenting. One of our other speakers today is Nafi, who is the Multicultural Liaison Officer in New South Wales Health. And Nafi, would you like to let our participants know what you do in your job?
Sure. And thanks, Leslie. Hello, everyone. It's a pleasure to be here, and thanks for having me.
That's right.
Can you hear me?
Yep, absolutely.
As Leslie said, I'm Multicultural Health Liaison Officer in Hunter New England Health, that is part of New South Wales Health, and my job is mostly liaising with health professionals regarding challenges and specific needs of culturally and linguistic diverse patients, both in acute care and community setting. And I do some trainings, and especially about cultural competency and how you use the interpreter for health professionals. I'm also do some consultation and some groups with community regarding some health literacy. And also I'm a community and consumer involvement CCI in Hunter Medical Research Institute in Newcastle. And I'm a member of Center for Women's Health Research. And also I'm a member of Hunter New England Human Research Ethics Committee. And also I'm an early career researcher as well myself. And my area mainly is domestic violence among cult communities.
Fantastic. Thank you so much, Nafi. And last but not least, we have Associate Professor Jackie Boyle, who is the chair of WHRTN's National Steering Committee and is an inaugural member of the Consumer and Community Subcommittee. She's an academic obstetrician gynecologist and head of health systems and equity at Eastern Health Clinical School and Monash University. So we have some wonderful talent with us today, imparting some terrific knowledge and wisdom in and around CCI. So I'll just give you an outline of what we're going to be talking about today. We'll go over briefly what co-production is and what it does for those of you not familiar with it, and those who haven't worked on co-produced projects before. We'll look at the value that consumers bring to the research space as co-producing partners. We'll get some reflections from Kathy Liane, who you've already heard from, who did our beautiful acknowledgement of country. I'll talk a little bit about recruiting consumers, and then we'll look we'll have some reflections from Nafi, who you just heard from. And then we're going to have a Q&A section where you can add comments or you can ask any of the speakers questions. That includes Jackie too, who will be joining us later, I should say. And then I'll just touch on the next webinar in June and September that we're going to be presenting, which is part of this trilogy series. So I just wanted to start off by looking at the difference between involving, engaging, and having consumers participate in research. Monash Partners offers 3 really good, clear and distinct descriptions of these 3 approaches to working with consumers in health research. And they are participation, which is where patients and consumers are participants in a project and data is being actively collected from them or about them. Engagement, we often use this term consumer engagement as to mean all of these things, but indeed engagement actually involves the sharing of your findings and outcomes of a project where you're asking consumers to comment on or provide additional comment to what you've already discovered or what you're producing. But this is the big one that we're dealing with today. Its involvement is consumers and community working alongside health professionals and researchers in partnership, in equal partnership, to shape what research or project is done, how it's carried out, and how results are shared and applied in practice. So this is the I in CCI, if you will. And so I'm just going to ask, why do we need consumers involved in our work as partners? Well, the Australian Commission on Safety and Quality in Healthcare Standard number 2, partnering with consumers, might give us a clue. It makes statements like patients are partners in their own care to the extent that they choose. They say health service organizations communicate with consumers in a way that supports effective partnerships. So I guess my question is why? Consumers are partners in the design and governance of the organization. Why? Why do we need them involved in designing and governing organizations? Well, I think the answer lies in the background of the standard. So the background states that patient and consumer partnerships are a pillar of person-centered care. And that is a care that focuses on the relationship between a patient and a clinician and recognizes that trust, mutual respect, and sharing of knowledge are needed for the best health outcomes. And I guess this is, in a nutshell, pretty much why we need CCI in all areas of service delivery, from design to planning to governance to development to strategizing. It has the ability to improve health outcomes. And that's really, I think, our universal shared purpose between consumers and researchers and clinicians and all stakeholders in this space. So there's a myriad of descriptions attempting to ameliorate the definition of co-production. So sometimes they're used interchangeably with terms like co-design, for instance. Co-design refers to consumers and researchers working together on the creation of something like an app or a gadget. Co-production can refer to something like consumers, clinicians, and researchers producing service guidelines or working with bureaucrats to produce policies, that type of thing. But I think rather than concentrating on any specific definition, I mean, some of them can be pretty abstract. I don't know if you've been on the net and had a look. Some of them I don't even understand. But it might be more helpful to look at co-production as an action rather than a thing. And there's a resource that comes to my mind when I'm talking about this that's produced by the Social Care Institute for excellence on co-production. It's quite useful in this context. And according to the SCIE, in their resource entitled Co-Production, What It Is and How to Do It, the Institute states that co-production is basically a set of activities, like co-designing, including planning of services, in our case, research, co-decision making in the allocation of resources, co-delivery of services, again, in our case, research projects, and of course, co-evaluation, co-evaluating with consumers as partners. So let's look at the principles of co-production. Another useful definition, which I like, comes from the UK's National Institute for Health Research Principles and Success Factors for Co-Producing Research. And this is what they are: sharing of power, where research is jointly owned and people work together to achieve a joint understanding. For a lot of us in research and in clinical work, that's quite a challenging thing. It includes all perspectives and skills, where the research team includes all those who can make a contribution. Everyone is of equal importance, respecting and valuing the knowledge of all those working together on the research. Reciprocity, where everybody benefits from working with each other, and the building and maintaining of relationships, where there's an emphasis on relationships with a focus on joint understanding and consensus and clarity over roles and responsibilities. So there's 8 success factors that underpin the Institute's principles of co-production, and they provide a framework for planning, delivering, evaluating, co-design and co-production activities, establishing ground rules, ongoing dialogue, joint ownership of key decisions, commitment to relationship, all those that you see on your screen there. Flexibility, I would actually use that word as agility, or sometimes we say iterative processes, where we need to be able to move and change with things that present themselves, new things that present themselves. And of course, continuous reflection. And I'd have to say that's not only about your own work, that's actually about yourself. And that's what comes out in the co-productive process. So let's look at the value of co-production. What is the value of co-production? Well, the Australian Commission for Safety and Quality in Healthcare states that co-production helps make research that is more relevant, meaningful, useful, and vital in shaping the health needs of women across a variety of diverse backgrounds. The value of co-production is not just learning how to do something differently that's more valuable. It's also about learning about yourself in terms of how you grow and operate, not only as a researcher, but as a partner, how you value partnership. There's value in co-production when there's a willingness to acquiesce and a willingness to open to different approaches and opinions. And that includes both consumers as partners, as well as researchers as partners. There's value in going to the uncomfortable and being okay with that. I mean, we all come from different points of view, different standpoints. You know, we need to push through competing agendas or conduct uncomfortable dialogue. Consider how compelling trauma can be for a consumer who's experienced something, or how confronting the dismantling of the power dynamics can be for researchers and clinicians. It's hard. This is new frontier. We've been talking about it for a while, but actually executing it is difficult. But by going to the uncomfortable, not only because the process is unfamiliar to you, but because you're willing to go there, the new can emerge. Innovation can emerge. New ways of doing, new ways of feeling, new ways of succeeding and understanding your work more deeply and why you do it. I can't actually help but think of a session that I was in at the end of last year, I was at the Health Services Research Conference in Sydney. And there was a session on how to work with Indigenous people. And what emerged from the discussion in the session was that the Indigenous people in the room, and we're including researchers like Yvette Rose, for instance, they were requesting a new and better way of conducting research, a way that's more relevant to Indigenous people, where the criteria even for measuring outcomes, measuring data, it was completely different. And this is what we're talking about. By working with consumers, we'll discover those types of things. So let's talk about value with CCI at the moment. So consider what the Social Care Institute for Excellence acknowledges when talking about the value of co-production. It's the effect on our social realm that also adds value to our work, as much as is the conducting of the research. So it says the contribution that co-production makes to developing social networks and communities is another benefit. Now, one of the best ways we can do that is first by connecting with our communities. And one of the ways we do that is that we make sure that our consumer advisor advocates we invite to participate in our co-productive work are connected to networks and communities. So this is part of the selection criteria for Wharton's consumer recruitment process. And this is highlighted in our recruitment documents that we circulated to our centers not too long ago. Not only do we look for consumers that collectively possess a lived experience, they have systems knowledge and health and/or research committee experience, we actually look to see that they are well connected to consumer networks and community so that they're able to bring a broader voice to the table and to our research projects. This is why I'm calling on Kathy Liane, and while I'm calling on Nafi this afternoon, because they are so beautifully connected into networks and into their community. So the SCIE goes on to say, it's been argued that this only happens, we're talking about the developing of social networks, where there is collective co-production with groups and communities, and not where co-production is confined to individuals being involved in the services they receive. So in other words, it's not just the lived experience that is powerful. It is actually the connection to our communities and those people sitting at the table that have those connections to our communities that brings that broader voice to the table. So enough about listening to my dulcet tones. I'm going to bring in Kathy Liane, who you heard from earlier. Kathy's a Darug woman on Kaurna land, originally from Sydney, but now in the Adelaide area. And Kathy, I'd like to ask you a couple of questions. Are you there? Can you hear me?
Yes, I am.
Okay, that's great. I just wanted to see if you could provide some of your perceptions of what it's like being on a committee, not only on a committee as an Indigenous woman sitting on a committee with non-Indigenous people, but also being an Indigenous person on an Indigenous committee, for instance. Can you give me some reflections on that?
Well, two quite different experiences that you've highlighted there. Being an Aboriginal woman on a predominantly non-Aboriginal committee can feel quite isolating and is hard to raise your voice and say what needs to be said. Often what we value and how we see things should be progressed is very different from our non-Aboriginal colleagues. Whether that be in a workspace, in a research space, or even in a community space. So you can feel quite isolated, and there's shame in speaking up. The other thing I find about being a lone voice is there's often an expectation that you are there to represent the whole Aboriginal community. And that's certainly not possible for one voice to do alone. The Aboriginal community is very diverse. You know, there are over 300, 400, 600 language groups across Australia, and within that, you know, a variety of cultural practices and perceptions. And even within a language group, you know, as with any community, there is a high degree of diversity. So to have a single voice, and a single voice that's expected to speak on behalf of all Aboriginal people, is quite daunting, and really is not possible. As an Aboriginal woman sitting on a committee or you know, in a network where it's predominantly other Aboriginal and Torres Strait Islander people, is very affirming. It's a very different feel. It's much easier to put forward your opinion. It's much easier to share. There is a greater sense of support and understanding. And while there may be diversity, there is a shared experience, shared understanding about things, which is very affirming. It is a very, 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 very different feel.
Yeah. And you talked about feeling isolated on a committee where you're the only Indigenous person. What do you think we could do to alleviate that?
Well, I think, you know, the easiest thing is not to have just one person.
Yeah.
Make sure that when you're seeking representation, that you actually have enough capacity for a number of people. And if you're working well with community, it would be asking community who they would like to see, you know, how many seats they'd like to have at a table. But yeah, one person alone is not enough. Sometimes you'll get, you know, there'll be two Aboriginal representatives because we know that, you know, one is going to be isolated. Even two, you know, at a table of 10 or 20 is still quite overwhelming. You may have each other for support, but it still feels quite tokenistic. It still feels like you're very much the minority. So it's about looking for balance. And that doesn't mean that, you know, half the people should be Aboriginal and the other half non-Aboriginal. But how do you bring balance to that? So having other consumer reps with a similar shared experience, if that's appropriate. It might be identifying, you know, Aboriginal researchers to also have as part of the team. It might be having key people who are able to, you know, have a similar lived experience or research interest, so that there are connections and supports, and people who are identified as allies, and are able to amplify the voice of those one or two or three Aboriginal people in that context. The ideal is at least 50-50, but you know, my ideal is to have, you know, a cohort of predominantly Aboriginal and Torres Strait Islander people, whether they be researchers or consumer reps. But definitely look for those connections, similarities. I'm seeing Nafi's face there, and I know we don't like, you know, it's inappropriate to put our culturally and linguistically diverse communities in the same cohort as our Aboriginal and Torres Strait Islander consumers. However, there are commonalities that we share, experiences of colonisation, of racism, of isolation, of being a minority. So depending on what it is, I mean, sometimes those shared experiences and having a cohort of consumers with similar experience, they don't all have to be Aboriginal and Torres Strait Islander, but that in itself can be a good support and help amplify the voice and reduce that sense of isolation.
Thanks for that. Just one other question I've got for you, Kathy, too. Just let's talk about research and how around research, you and I were having a conversation earlier on this week about research and how it's framed in needs and gaps. You talked about maybe deficits shouldn't be researched as much as something that's sort of more affirming, I guess, and strength-based. Can you kind of talk to that a little bit?
Yes, so just stop me if I talk too much, because I think it's something that as an Aboriginal woman has certainly framed for a lot of my life, my experience of research, in that research, Aboriginal people are some of the most researched people in Australia. Mm-hmm. The amount of research out there, it blows my mind sometimes how much is being conducted on us, but most of it has not been conducted from our own perspectives of ourselves. It's mm-hmm. being conducted from a European, a very Western construct, which has identified deficits in our behaviour, in our circumstance, and it has been a focus on these deficits. I think the example I provided when we were speaking, Leslie, was around the overrepresentation of Aboriginal children in out-of-home.
Yes, yes, that's right.
How a lot of research is conducted around, or has been up to recently conducted around, what's wrong with Aboriginal families? Why is it that they're unable to parent their children? What are the supports they need to be able to better parent their children? Whereas I'd like to totally reframe that research, and I know there are Aboriginal and Torres Strait Islander researchers out there who are very much doing this, and it's about understanding the impact of colonisation. It's understanding that colonial perspective and what that has meant for Aboriginal families. It's about exploring the strengths of Aboriginal families and how systems have been contrived against us. But mm-hmm. how do we work with Aboriginal families to build those strengths and acknowledge those strengths and bring those strengths to the fore when we talk child protection? So yeah. Okay. It's about conducting that research, understanding problems, but from an Aboriginal perspective, from a strengths-based perspective.
That's fantastic. Thank you, Kathy. Nicole in the chat box has actually raised a really good question, and she has said, how do we as healthcare professionals and researchers ensure we reach people from the difficult to reach people to ensure good representation? And she said, I guess my question is around equitable representation, which actually it is. And we're actually going to touch on that in the next of the two, and the second and the third webinar, that the one that we'll have in June and the one that we'll have in September. We're actually going to talk exactly about that. How do we do that? If you've got any other insights to that, Kathy, in asking that question right now, do you have any type of answer for that?
To answer it very quickly,
mm-hmm.
is that it won't happen overnight.
Yes.
It's about building trust, and it's about building capacity. So you actually need to invest in hard to reach populations. Those people that are underrepresented, there's good reason why they're underrepresented. And usually it's about capacity and trust. So it really does need a lot more words than that to really go into it. But I think they're two key things.
Yeah, those are two key elements. Absolutely. Thank you, Kathy. Just talking about recruiting consumers, which is kind of in line with Nicole's question. We've, as I said to you, we have distributed to our centres some recruitment guidelines, and these documents were circulated last year. And there's a couple of key points that I would say that were highlighted from those recruitment documents. Look for putting diversity on your teams, not only the lived experience that's relevant to your research topic, but people have systems knowledge, cold women, which Nafi will talk about, Indigenous women, women connected to the community. And this is one that's really important to women without clinical backgrounds. So we want to try and keep that consumer voice really independent. We want to have a different perspective at the table. If we already have clinicians and researchers there, we want women who do not have that clinical background, so that can we really, really bring a different perspective to the table. The other thing to consider too is remunerating consumers for their time and expertise. That not only talks about the time in your work together, but also outside in terms of reading time, reading documents and all that, or even writing documents, that type of thing. They may co-write with you. Also, anything that's required outside that as well, as in child minding, accessing facilities, all that type of thing needs to be taken into account. In answer to Nicole's question, local councils are a fantastic resource to finding populations with whom you want to link in. And we'll touch on it in the second one, but we'll really touch on that in finding those underserved populations that you really want to connect with through local councils. It's not the only answer, but indeed it is a fantastic way of finding those communities, because those local councils have people like multicultural liaison officers or inclusion officers, and they are directly linked into the community. So that is a wonderful resource, and we'll show you how to do that in the next second and third series. So I'm going to bring Nafi in into the discussion. And Nafi, you work with CALD women, culturally and linguistically diverse women in your line of work. And I just want to know if you could give us a few reflections. We're running short of time a little bit at the moment, but gee, I'd really like to talk to you about things like issues that affect the health of CALD populations. Can you maybe reflect on that a little bit?
Sure. Thanks, Leslie. As Kathy was mentioning, talking, I just nod my head because there are some similarities.
Mm-hmm.
And first of all, the diversity of community is the same, and it's really annoying. Someone come to me and ask me why all immigrants do that. And I said, we got migration from more than 150 countries. So how can I be a representative of all CALD community and CALD women and answer that question? So we've got the healthy migrant effect. I don't know if you heard of that. The audience is just when the migrant arrive in host countries, usually the health and the healthy behavior is completely different and better than mainstream population. But after a while, the health deteriorate, and then in some aspect, the health is worse than mainstream population. And the reason for that is social determinants of health. For example, I can tell you some example like language barrier. The first thing that, people cannot communicate in English, so they cannot access health services. Lack of familiarity with the system here, like the health system here is a bit complicated, and navigating health system, it takes years to learn how to do that. It's some social isolation that CALD communities have, especially women in regional area, like transport, how to have access to care, because they are the main carer, they look after other children, or if there's any elderly in the family, it's the women's job to do it. So for them, the health comes, the last priority. And also racism, discriminative attitude is one of other reasons that usually CALD patient access health system with less and have less favorable health outcome in comparison with others. And there are other stuff as well, like immigration status. I had a chat with Leslie before about the patient who are not Medicare eligible. So the people who don't have Medicare, I saw in the hospital that women, especially international students or women who are on bridging visa, they just come have a baby, and even they have complication and they just discharge against medical advice. And the reason is if they stay, they need to pay $1,000. So they don't want to pay that money. So they just leave the hospital. And then, of course, it has some negative consequences. So yes, all these factors affects their health. Yeah.
Okay. So I do have a comment here in the Q&A section from Neha. they're saying many cold group people who are from overseas from medical backgrounds are not registered as a clinician in Australia for some reason, and why they are keeping away from giving their opinion as consumers. So Neha, I just wanted to ask you to put a comment in there. Are you saying that why can't they be consumer representatives in the space for cold people as well? Can you just answer that question in the Q&A, and I'll come back to you. And Christina has a question here, and she says, I've heard from people expressing that they dislike the term cold. Do we have any alternative terminology we should be using? Example, multicultural communities. Do you have any comment on that, Nafi?
I personally think just the terms doesn't matter, actually. And I have this in a conference. It was a whole session about cold and why we shouldn't use that. There are some, I don't know, some different opinions about it, but personally, I think it doesn't matter what you call what you call. Just we can call, and when you look at the international context, it's different thing. We've got like in UK, they got black and minority ethnic group. BAME is a big, like our cult is BAME, black and ethnic minority group. Yeah. Or in others, yes. And then in other culture, they usually have, in some countries, it's an immigrant and refugee. Some people call multicultural community. Yeah, you can use any of this.
It's all interchangeable. Yeah,
interchangeable. I think it doesn't matter actually, but some people, they don't like cultural.
Yeah, it's interesting, isn't it? And it's just a perfect example of how we're saying that we all think and are all different. Even if you sit perhaps in that multicultural space, so to speak, then some people will like certain terms and other people don't. In the United States, they use the term BIPOC, Black, Indigenous, and people of color. And if you use that here, people don't like that term, or some don't like it. Some go, that's okay. So it's quite a continuum.
Mainly in the literature, if you look, and even when I was doing the scoping review, I found that you cannot avoid it because it's used a lot. So you have cost, especially in your research.
Absolutely, it is. I was just wondering, Nafi, if you can just touch on something, which was you told me a story about we were talking about being left out of, you have great expertise, but sometimes people don't hear you, or you get left out of certain things. And you've talked about racial discrimination, all that type of thing. You touched on a study that somebody was doing on alcohol consumption. Do you remember that? Can you kind of reflect on that very quickly?
And I think it's not just about me, and I don't even believe that I'm the expert. I have some experience I can share, and it's not just about me or some person, but the important thing when we talk about co-design and co-development of research, it needs to be someone, as you talk, and Leslie talk and Kathy talk, it's a diversity of community and representation. So it should be someone that is working closely with those community, and from those community needs to be in that research project. And the main thing is the topic that you choose. I was talking to Leslie that it's really sad that it was a project was happening here, and they were, I don't know, a couple of 100,000 they spent on that, and it was about alcohol consumption among Muslim immigrant women who are pregnant. And when I just came across that project in the middle of it, and I just said, wow, the person who does it, actually, they were all had no clue they are Caucasian, and have no clue that most majority, and again, we cannot generalize, but majority of Muslim women, they don't drink. Especially during pregnancy, even if it's not religiously, culturally as well. And it was amazing. And the result came even with other Asian communities in the other nationalities. When they compare with other like Eastern European or European and the Western countries, most of the people from cultural and linguistic diverse, like Asian, Indian, different culture, they don't drink during pregnancy.
Mm-hmm.
Don't show that. And so you think why you don't ask some of the community member, just go to some of the consumer representative in the hospital and ask them, Or even we have some health professional in the system. We got doctors and nurses and midwives and social workers. Just ask them, just have a little consultation. So it's some of those things that happens is there. Or sometimes they ask us, I as a multicultural team, I've been asked to participate in some project. It was another project and I was so happy. I said, oh, that's great. They asked us from the beginning about this project. It was about the diet and the food with children, children from cold background, that especially lunch boxes. And I spent half a day and just tried to give them feedback about the food that it was all the food it wasn't like a pictures. It was a pictorial materials, and it was all white food, like it was Vegemite sandwich. It was, all Australian food, pie, and and they said what, and I just give them some example, and some especially for some cold community and refugees, especially that area that they were working was newly Arab refugees. They make their own bread, and I said it's like a flat bread, so you can it's not a big deal. You can just put a picture of a flatbread, so it's more clear, it's more cultural. They were rather putting a Vegemite sandwich there. So, but I make those comments and I never see them incorporated. So it's another thing that is just a tokenistic thing. They just want to tick the boxes that we have a person there. Yeah.
That's a really good point. So they brought you in to ask you questions about how they can do something, how they can produce something really well, and didn't listen to you. So when we're talking about co-production is it's a partnership and it's about listening and understanding and using what each other is saying so that you can produce better research and or resources, really. There's a comment in the Q&A from Linda saying excellent reflections, Nafi, and she said, I've seen lots of cold female patients who are too afraid to speak up due to cultural morals, which you completely have. You've talked to me about that several times. So, and she's asking, how do we help empower female patients to speak up in research projects?
Just ask and ask them and get them involved. And we've got so many places that you can involve called communities. It's lots of settlement services. And I'm sure I'm based in Newcastle, but I'm sure in Victoria, everywhere in each state, they've got settlement services. They've got SSI. We've got Migrant Resource Center. As Leslie mentioned, there are some councils. Even at university, in health, in each hospital, they usually have so many bilingual workers and people from cold backgrounds, so they can ask them. And some of them, as someone mentioned, like highly educated people who are here and they are not like overseas trained doctors, that they are not allowed to work here. And actually, we have two of them in one of our consumer representative in multicultural health. A wealth of information, so it would be great to get them, involved.
That's a really good point, and it's actually some research that I did with my master's degree a few years ago, which was one of the discoveries I made. It was about engaging with populations. Was actually you need to go out into the community and find them, and you can't ask them to come to you. So and those are terrific resources that you've just mentioned. Thank you so much, Nafi. I'm going to now move on to we have been in a Q&A session with you, but I'd like to open it up to the floor a little bit more, and there is some more questions and answers in the Q&A box. I'd also like to invite Jackie too. Jackie, are you with us at the moment? Because I can't see with my screen if you are here at the moment.
Yes, I am, Leslie.
Oh, that's great. Thanks so much for joining us. I'd like to open up. Did you want to make any comments, Jackie, about what you've heard so far and what's been said? Because I know that you're passionate in the area of health equity, especially with cold and Indigenous communities.
No, I'd like to thank all of you, actually, to start with. You, Kathy and Nafi, it's been really good, and also to thank you for your contribution to WHRTN. It's been fantastic over the years. In terms of research, I think that, we often do just go to the easiest communities to reach, and I think that reflects on us, not on them. And so I think, that's really where the consumer and community involvement is so important, because, if you build that trust and those relationships, then that will enable you to have more diverse representation in your research participants and to understand what you're doing better. It just improves the whole process, and I think it's not only better research, but I think we learn a lot, and it's better for us as well as being better for the community.
Here's a really good question from Melody. Do you have any advice for small unfunded research projects and CCI? She's a student.
Yes, I did say that. It's always tricky, Melody. I think certainly when you're applying for grants, it's always important to try and include some budget for CCI. And I think that, it's always good to ask your supervisors if you can really, if they're valuing equity and consumer and community involvement, then, it's not, it's really, in terms of budget, usually a small part of the overall project, and certainly should be feasible to contribute to your project. To ask, good luck with asking for that.
Yeah.
But yes, it is tricky as a student or an early career person who doesn't have a large budget, but I think it's just always important to remember to include it in your budget when you are applying for grants and things.
I've got a question here from Rebecca. Can you please advise how we would go about seeking relevant groups within the community? For example, consumers with a history of incarceration. There are groups who actually care for people who come out of being who come out from jail. And I do remember one that I was briefly involved in. It was called Flat Out, which I think was a beautiful name, and it looked after women who had come out of incarceration. And integrating them back into the community. There are organizations that actually, and there's more than Flat Out. Let's have a look. Bronwyn from me, do you have a view on shifting the CCI conversation to people-centered approaches to care health service delivery? It seems to me the principles that underpin this approach align with co-production, engaging and empowering people in the communities. Bronwyn, I'm just wondering if Bronwyn can actually ask that, not in the Q&A. Can we have a discussion or a quick chat here now? Linda's Bronwyn able to come on and talk?
No.
Okay. Perhaps if we can provide Bronwyn with my contact details, I'd probably prefer to speak to her, more in depth, and we don't have enough time at the moment to do that. Okay. I'm just going to see if there's there's no more questions. I'm going to move on just our last slide, which is just to say that the webinar 2 and webinar 3 are happening in June. This next one, I know you had a lot of questions there about linking in with underserved populations. This one is for you. We're going to have even more on that webinar. You won't see much of me in that webinar at all. And in webinar 3, connecting with local councils and communities, we will also have some people involved in that webinar who are from councils who have done indeed that. Somebody who's a multicultural liaison officer, also somebody who from Western Australia who specializes in linking researchers with local communities and has a couple of case studies of how she has done that and how highly successful it has been to help improve outcomes in that area. So I would like to thank I'm sorry we've run out of time at the moment. Bronwyn, if you can be in touch with us and get my email, and I will endeavour to answer your question in more depth, because I'm really interested to answer that one as well. So I'd just like to thank everybody for attending. I'm sorry that we've run out of time. I'm hoping this has helped you, and I really, really look forward to seeing all of you in the second and third webinar as part of this CCI Trilogy series. So thank you so much, everybody.